Thank you very much, Dave. And I think you've done a very stellar job in actually explaining the FLAIR trial and where we are with that trial at this moment in time. My job is now to take you through static trial because that is partly kind of related to FLAIR trial in some ways as well. This is a trial which we also can see because a lot of patients on FLAIR study, as you can see in the previous slides, that the ibrutinib treated patients have been treated for up to 6 years in FLAIR trial. And then we want to look at this question in this trial, whether everybody should continue long-term continuous tablets every day for longer period of time. So why to do static trial? This is a nice cartoon which explains some of the reasons why we wanted to do this trial. So this is some data that has been published in other cancers, such as prostate cancer. And the main concept is that if we are going to start the therapy, and right at the top in the top cartoon, you can see there are lots of purple cells, which are the cells which are sensitive to a treatment. And there is one cell which is resistant cells. And if we keep giving the same drug for a longer period of time, what happens in other cancers that the resistant cells start to accumulate and the sensitive cells continue to decrease in number. So eventually what we're doing with continuous therapy is breeding out the resistant cells. And that might be true for some specific cancers, mostly solid organ cancers. But what the cartoon down below will show is that the purple cells, which are the sensitive cells to different kind of treatments, if we give treatments which are intermittent, you may form a few more resistant cells, but actually over time you've got a mixture of a tumor which is sensitive to the treatment as well as some accumulation of resistant cells. And in other cancers like prostate cancer and breast cancer, when this approach has been taken, that you give intermittent therapy, what it has resulted in is that there is a longer duration of response to therapy. So what we're trying to look at this question is in CLL is that if we give intermittent therapy to treat the CLL clone, whether we will reduce the resistance. And obviously, if we are going to stop the drugs, then we might reduce the risk of side effects from the therapy as well. So these are important questions that we wanted to ask in static trials. So hopefully that makes sense. Next slide. We know there's a lot of information that we've gathered from FLAIR trial, and Dave has very nicely got through some of the data, but this is looking at some more data which is relevant to static trial. And we have presented this at last year meeting in US again. We now have data that 61 patients in the ibrutinib and rituximab arm of the study had progressive disease, which means that the disease has now progressed on ibrutinib therapy. And we found that some of the patients have got resistance because the place where ibrutinib or these new drugs like acalabrutinib or zanubrutinib bind to, that place has mutated. And once that's mutated, what happens is that the disease starts to progress. And that is one of the reasons 1 in 5 patients have had resistance due to that. But another important information that we have been able to accumulate that when we give 6 years of therapy with ibrutinib or ibrutinib with rituximab, there is very little disease which is left to treat. So the amount of disease that was at start was very, very high. And now we've got very, very little disease at the end of 6 years. Next slide. So that takes us to static trial, really, and it's a big trial. We are looking at 800 patients. And what we want to look at the question that if half of the patients, and this is a thing we use in the clinical phase 3 clinical trials, that the randomization happens, and that is done by a computer system. Half of the patients who are on ibrutinib will continue to receive ibrutinib. So that's 400 patients, and the other 400 patients will stop ibrutinib. And the main difference would be that when the disease starts to progress again, then patients would be able to restart therapy again. And once they restart therapy, if the disease goes into remission again, then they would be able to stop therapy again. So, what we want to see is whether intermittent therapy is as good as continuous therapy, or this approach leads to the same outcomes or even better outcomes for our CLL patients. And that's the main question that we're trying to ask in this study. And essentially, there are some things which are called the primary outcomes and secondary outcomes, which are on the box. What one of the most important question is really, is this approach is the right approach or not? But then also very much important question is quality of life in this trial as well, and we are collecting data over time. Next slide. So we have got, just to confuse you all again, we have got some inclusion criteria. We have got actually three arms of the trial. One is the clinical need cohort, and these are all the patients who have had ibrutinib on FLAIR trial for 6 years, and now it looks like that disease is stable, but we can't, there's still some disease left there to treat. And for those patients, the 30 patients would be able to continue ibrutinib. So they would not go through that randomization process. So there is no randomization for those patients. The clinicians can recruit patients into that arm. But then there are 360 patients who will be coming out from FLAIR trial only. And we know, and part of the reason for that is that after 6 years of ibrutinib therapy, we don't have access to ibrutinib in UK. And we want patients to go into static studies so that we can look at this important question in the trial. So half of those 360 patients will get continuous therapy, and the other half will go into the intermittent therapy group. And then there is another cohort, which is the previously treated participants, which is 440 patients. And this is the group of patients we're looking for who have been on ibrutinib for 3 years or more. Now, this is a different group from the other group I've talked about. This is the group who have got CLL, which has been previously treated, say, with chemotherapy, and then they got ibrutinib, and they have been on the drug for 3 years or more, and they are in clinical remission. So we are looking at this group as well. When we did this trial, we had some issues because of the COVID pandemic. We had to initiate the trial later on, so it took us more time, nearly delayed by 1 to 1.5 years. And already some patients on FLAIR trial have already stopped ibrutinib. And I think one of the issues we encountered since we last spoke to you as well was that ibrutinib use in UK has been reduced substantially because of the advent of the new drugs that David has very nicely shown you. And we had less number of recruiting sites as compared to FLAIR, and Rhiannon will talk a bit more about that. Next slide. But here is the change. So this is the important thing that I want to emphasize in static trial, is that the clinical need cohort is exactly the same. There is no change there. But for the frontline randomized cohort, initially we were just getting patients from FLAIR, but any patients in UK who have been on ibrutinib for 6 years or more and have never received any other therapy can move into this trial as well. So we had some other patients who were on different trials, and they can move on to this study now. And there was availability of ibrutinib in Scotland or private sector, so those patients can move on to static study as well in the frontline cohort. But for the previously treated participants, so remember these patients had chemotherapy in the past, and then they moved on to ibrutinib. But now we are also will be allowing acalabrutinib treated patients who have been treated for 3 or more years and are in clinical remission. And those patients would be allowed to go into the study as well. Now, this is what we call as an amendment of the trial. And at the moment, it's being approved by the sponsor, and then it's gone through the ethics committee. And we're hoping to implement this at the start of coming year. We are not still open for this. I will be very clear about that, but we are expecting the sites to implement this change, hopefully in January 2025, and then we should be able to get a larger group of patients going into this study. And we certainly hope that that will help us to answer this important question of continuous versus intermittent approach in CLL. So I think this is my last slide. And like what David said, yes, it's up to us, but I think none of the trials or none of the work that we're doing can be done without your support. So your voice is extremely important in all of this. So thank you for listening to us, and I would be very happy to answer any questions that you may have.
Thank you very much, Tal and David.